So the amyloid is a mediator. It's not the cause. So what happens is your brain recognizes when you have changes. For example, you've got a change in your oral microbiome, and there is connection there. You can have a change in your rhinosinual microbiome. You can have leaky gut. You can have exposure to toxins. You can have metabolic changes, on and on and on. And it responds to those by producing this stuff, amyloid, which is a little bit like taking molasses. And what it does is it surrounds the pathogens, sequesters them, isolates them, and inactivates them. So when you start having, this is again why P. gingivalis, one of the oral pathogens, when it gets into the brain, you make that amyloid, which coats it and inactivates it. So what we're learning is that all of these different proteins that have been associated with neurodegeneration, and of course the claim has been they are misfolded proteins, quote, and that's an outdated thought process with respect to these diseases. These are all antimicrobial proteins. In other words, they are part of your immune system, and specifically your innate immune system. So they are upstream. And my argument is that they're actually upstream from the upstream in that they are a pre-inflammatory component. In other words, if you have small amounts of these various pathogens, you can get away with just coating them and not activating inflammatory pathways. And indeed, that's exactly what you see. There are people who will walk around with amyloid in their brains for 20 years and think just fine. So your brain is really trying to help you out. When you activate the inflammatory pathways, now you are losing synapses. Now you've got complement on these synapses. You're losing them. You're pruning them, and now you're really pulling back. And you've got a bigger war. It's a little bit, like, can you fight a little skirmish and just keep things localized, or are you going to go into a much larger war? It's that inflammatory war going on in your brain that is giving you the symptoms of Alzheimer's. So the amyloid, again, it's a marker, but what it's really telling you is that your brain has recognized insults and has now used this to sequester, isolate, and inactivate these various pathogens, toxins, etc.
All right, important we went there early with the amyloid and explained that. For somebody that now understands the role of it, not being causative, but a sign that there's an insult, can somebody go about getting assessed to see how much amyloid is in the brain? Or is this something they're only doing an autopsy? And the reason I ask that, because if somebody could easily assess that and find that out, that would be a clue we need to go deeper and find out what is actually causing the brain to respond that way.
Yeah, that's a really good point. And there are 3 ways to do it. And now there's a very easy way. And we should all have this checked. I just had mine checked a few months ago. So the first and the classic way is an amyloid PET scan. But that is expensive and you're getting radioactivity. You no longer need to do that. Second way is a spinal tap, and I certainly don't want spinal taps every few years. So the good news is you can now get this same information from a blood test. Very simple. And so you have a blood test, and actually there are several groups that do this. The one that has the most sensitive version is called neurocode, and they look at your p-tau 217, and they've now done tremendous correlations with over 1,000 different specimens, autopsy specimens, for example, looking at all this. The p-tau 217, which is what you want to know, correlates literally over 95%. It's almost a perfect correlation with how much amyloid is in your brain. So you can see your p-tau 217, you want it to be below 0.34. If it's starting to drift up, and again, there are 4 groups you can be in here. So less than 0.34 on that particular test from Neurocode will tell you that you are the normal range. And I recommend anyone, again, over 35, just check it every 5 years. You don't need to do it every 6 months or every year. Every 5 years is fine. It's very much like checking your hemoglobin A1C and to see if you are headed for diabetes, or checking your lipid panel to see if you've got any issues vascular. This is going to be the same sort of thing. So it gives you a warning, something you can do a lot about. There's the second group, 0.34 to 0.47. That's in the intermediate group. It's nothing to worry about, but you just want to then check it again the next year, see if you're going in the right direction or the wrong direction. The third group, 0.47 to 0.63, that's saying that it's higher than 95% of people who have no cognitive complaints and have no amyloid in their brain. So that's beginning to get worrisome, but it's still not in the highest group. If you're at 0.63 or above, that says you are likely to have amyloid and you're likely to have at least some degree of compromised cognition. So get on it now. People shouldn't worry. Whatever your score is, don't worry, because there's a lot you can do about it. The main thing you don't want to do is wait until you're really heavily symptomatic, because the earlier you start, again, no different than cancer, the earlier you start, the more you can do about it. I mean, look what the huge difference Pap smears made. Women stopped dying from cervical cancer. With the introduction of the Pap smear, it became much less common. We'll use things like colonoscopies and PSA for prostate, all these things that have made such a huge difference in our health. So again, everybody should know their p-tau 217. Know where you stand, and then check it again in 5 years, see where things are going. And if you're on the wrong side of the curve, again, don't worry about it. Get evaluated. Then the next set of tests will tell you what's driving it. Do you have poor methylation? Do you have specific pathogens? Do you have specific toxins you've been exposed to? Do you have metabolic abnormalities, which 100 million Americans have metabolic syndrome? It's one of the most common contributors to cognitive decline, and yet most doctors aren't really checking for it. So these are the things you want to know, and then you can get on an optimal precision medicine type program, and you can reverse whatever decline, and you can dramatically reduce your risk for getting dementia.
All right, we're going to come back to metabolic syndrome. I want to spend a good amount of time there and metabolism changes in the brain. But let's stick on amyloid for now.
Yeah.
One more question in that realm. Given our new understanding of what that's actually doing in the brain, somebody that's progressed down the line and they know they have a significant amount of amyloid in the brain, is it best just left alone?
Yeah.
Or what do we want to do goal-wise?
Yeah.
Given that we know that it's actually protecting from some sort of insult?
This is such a crucial question because, as you know, the pharma approach has been, let's give you an antibody to suck out that amyloid out of your brain. The problem is, one of the things it does is it patches vessels, and so that it's a little bit like having a patch on a tire. So when you suck that out, what do you think happens? The blood vessels leak, and you get microhemorrhages in the brain. You get brain swelling. There have been a few deaths. So it's a significant issue. Now, I think in a perfect world, what's going to happen is that we're going to remove the problem first, and then we're going to slowly remove the amyloid down the line. What's happening is that you want to determine what's driving this, and you want to just decrease the inflammation, because you have to remember, the big problem is not the beginning of the amyloid, it's the inflammation that comes on top of it. So, for example, amyloid kills candida. Amyloid inactivates herpes simplex. For example, it's viruses, it's fungi, it's bacteria. It's really a remarkable antimicrobial and antiviral agent. So what you want to do then is just as you said, don't just take it away. For one, you're going to have some potential brain bleeding, but for another, you're going to take away something that's actually helping you to deal with ongoing insults. So first you want to take away the insults. You want to optimize resilience. So it's removal, resilience, and then rebuilding. You want to build back what you've got. And as I say, early on, you want to get rid of that inflammation. Now, after you've done that, so after you've gone 6 to 12 months and you're doing better, now look and see how much amyloid do you have left in your brain. Some of it's going to be removed just by the fact that there's turnover. This is a dynamic process. You're making it, you're turning it over. Normally, you don't need it, so it's just going through. You're making very little. When it's called upon, when you've got the pathogens, you're now going to keep more of it in the brain. You're going to use it to sequester these pathogens. So what we want to do is see if it's now cleared out. For many people, you will clear it out just by getting rid of the insults, being healthier, getting optimal detox, all that sort of stuff, all the things we know that give you better health. But for those who then still have a significant amount there, now there are some things that you can do to remove it. Curcumin, for example, is one of the things that actually binds quite tightly to the amyloid and helps to remove this. And Dr. and Professor Greg Cole and Sally Frauci down at UCLA have done a wonderful job over the years at working with and studying the effects of curcumin on amyloid and the reduction of amyloid. But I do think that there is potential role, and my hope is that the pharmaceutical companies will be convinced of this as well, for waiting until you've done precision medicine for, again, 6 to 12 months. Now, if there's still significant amount of amyloid, come in with some microdosing to begin with, lower doses, and just slowly, don't rip it out of the brain, just slowly encourage it to leave the brain. In other words, since it's a dynamic process, you're tilting the scale toward removal instead of accretion. And over time, there's a very good opportunity for that to be reduced. And I think that's where things are headed in the long run. I think this idea of going in, doing nothing else, and massive doses of this stuff to rip this out of your brain, that's going to be outdated pretty quickly. We know from the trials, for example, that when that is done, number one, you don't make people better. So the breakthrough has been that you slow the decline a little. Well, for people who already have significant decline, that doesn't help a lot. All you're doing is slowing the fact that it's getting worse. Second, it doesn't slow it that much. In women, it slowed it by 11%, so barely. In men, it was about 35%. Okay, a little better, but nothing slowed it, 70, 80, 90%, which is what you'd want. And of course, in a perfect world, you'd like to reverse the cognitive decline, which is what we see with the precision medicine approach. So it's a modest approach, and it's very expensive, and it has all these side effects. So I think that that's going to turn out to be a suboptimal approach. And I think in the long run, again, the place is going to be for using this over time to remove the amyloid slowly when you're in good shape. And we have seen a number of people, by the way, that just got the anti-amyloid treatment. And with each of the treatments, they would clearly go downhill instead of up. So it's not without its problems.
Since you made it to the end of this clip, I know you're going to love the full episode. Click here to watch. I'll see you over there.
About 15% of our population dies of Alzheimer's. So about 45 million of the currently living Americans will die of Alzheimer's. We can reduce that number dramatically.